Welcome to our fourth nurse webinar of 2017, Nursing Solutions, Understanding Fatigue and Apathy in Parkinson's Disease. These series showcase the work of our nurse scholars who completed the Edmund J. Safar Visiting Nurse Faculty Program at the Parkinson's Foundation. Today's webinar features Amy Bruno, who is on faculty and the co-coordinator of the Adult-Gero Nurse Practitioner track at MGH Institute of Health Professions School of Nursing in Boston, and Dr. Nabila Dahodwala, who is an associate professor of neurology at the University of Pennsylvania. Before we hear from our speakers, I would like to just remind you that a PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the Parkinson's Foundation webpage highlighting this talk, or on the page you are looking at to the left. Health professionals can earn one free CEU through the American Society on Aging. Participants will receive an email after today's webinar with steps on how to collect the one CEU. You have just 30 days when the CEU is available until January 5th to collect the CEU. However, the program will be archived for an indefinite period of time. And today we're going to begin our program. Our objectives for today are that at the conclusion of this program, participants will be able to recognize the frequency and significance of fatigue and apathy in Parkinson's disease. Also, to be able to discuss the impact of these common non-motor symptoms on both patients and caregivers, to review recent research in the areas of fatigue and apathy in Parkinson's disease, and discuss how nurses can recognize and intervene with patients suffering from both fatigue and apathy. As you know, there are many issues that one faces when they have Parkinson's disease. The motor symptoms are one aspect, but the non-motor symptoms, as diagrammed on this slide, bring in a whole other host of realm of difficulties that a patient faces on a daily basis in many cases. This includes mood, cognition, motivation, skin changes, sleep, eye vision problems, decreased sense of smell, lack of facial expression, drooling, difficulties with handwriting, sometimes bowel and bladder problems. The problems really affect the whole individual. And as such, we know that fatigue and apathy are part of that. We also know that fatigue and apathy are very common and often overlooked. Patients may have a hard time expressing the symptoms. Instead, may have comments such as I'm weak or I'm tired. So it's often difficult to ascertain exactly what is happening. Caregivers, too, are impacted, as are people with the Parkinson's disease, as their quality may decline in their relationship and in their daily life. At this point, I'd like to introduce Amy Bruno, who is our first speaker. Dr. Bruno has devoted her recent research to the study of fatigue and Parkinson's disease. In 2015, Dr. Bruno published an extensive review of the current state of evidence-based medicine and research of fatigue. More presently, her work has utilized a qualitative descriptive approach where she has looked at how individuals describe their fatigue, how it affects their quality of life, self-management strategies, and patients' interactions with their healthcare professionals on the symptom of fatigue and its management. Dr. Bruno has presented her work at the New England Gerontological Advanced Practice Nurse Association and the Eastern Research Society Symposium in 2017. Dr. Bruno is a 2015 alumni of the Edmund J. Safar Visiting Nurse Faculty Program at the Parkinson's Foundation. Welcome, Dr. Bruno.
Thank you very much, Gwen, for that introduction. I'm delighted to share my research findings. This is from my dissertation that I completed in 2016. And I'm going to just start off with a little background of why I became interested in fatigue in the Parkinson's population. In 2008, I started to work with a movement disorder specialist, and after, I would say, about a month, I started to realize that one of the biggest symptoms that patients would bring up during visits, and if the patient didn't bring it up, their caregiver would be fatigue, this overwhelming feeling that kind of empowered their whole body and really affected their quality of life. So that was how I became interested in this specific non-motor symptom. So looking at the literature, we know that fatigue is a highly prevalent non-motor symptom in Parkinson's. It affects almost 60% of individuals diagnosed with Parkinson's disease. There's an older study by Zesiewicz et al. That actually cited the symptom of fatigue as the reason why people diagnosed with Parkinson's sought disability. The literature does report that this symptom is under-assessed at office visits by providers and actually under-recognized by people who have Parkinson's as being part of their neurological condition. And it's usually attributed to another condition, perhaps another coexisting medical problem like cardiac disease or depression, apathy, as we'll talk about, and sleep disorders. But it should be noted in the literature, fatigue is a symptom that can occur separately from depression, apathy, and sleep disorder. While there's overlap, it can occur with these other non-motor symptoms or in isolation. So when I started looking at the literature, what struck me is we have several quantitative statistical studies talking about, yes, fatigue is a problem in Parkinson's. Yes, it reduces quality of life. But there was really no data from the patient's perspective on how this symptom affects their life. There's one study that was done in 2013 in Sweden that looked at the experience of fatigue, but only in women. So I was hoping to kind of broaden that search and really look at data from the patient and find out, how do they experience this symptom? How does it affect their lives? So we know that, as I mentioned, many studies have shown that it reduces one's quality of life. The other thing I wanted to explore is, well, how do people manage this symptom? How do they live with it? What do they do that may help this symptom or reduce the way they reduce the fatigue that they feel? So when I went into the literature, there was absolutely, and there still is no studies done about self-managing fatigue. So I went into literature with multiple sclerosis, ankylosing spondylitis, and post-stroke. And there's a lot of literature about fatigue and those neurological conditions. So many of the participants in those studies identified strategies like having a positive attitude, taking naps, using pacing techniques, conserving energy, and social support, as well as reordering priorities, kind of restructuring what they had to do on a daily or weekly basis, as things that people did themselves to self-manage their fatigue. The other thing that is pretty compelling is in the literature, healthcare providers often overlook non-motor symptoms in office visits. And there was a study done that where 42% of the participants ID'd fatigue as a problem, but only were diagnosed as having that symptom at a rate of 14%. So based on literature review, my clinical interest, gaps that I identified in the literature, and also my experience working with individuals diagnosed with Parkinson's disease, I developed these 4 research questions. I'm going to focus for time purposes on 2 to 4 for this presentation. So I wanted to find out, how does fatigue affect one's quality of life? what self-management strategies do individuals with PD employ to either decrease or live with their fatigue, and are these strategies effective? And then how do individuals describe their experiences with healthcare providers in addressing their concerns about managing fatigue and its effect on their lives? So this study, because we have, as I mentioned, many quantitative studies that report statistical data, I did not need to do another study that looked at patients telling me fatigue is a problem. I wanted to find out from the patient's own lived experience how this was affecting their lives. So my dissertation methodology was qualitative descriptive, and just briefly, qualitative descriptive research really seeks to describe a straight account of a phenomena that affects a person's life. So again, the people living with Parkinson's-related fatigue are pretty much the experts in their own condition, and I really wanted to get that perspective. I utilized an interviewing technique developed by Rubin and Rubin, who are two sociologists. This allowed for this responsive interviewing technique really allows for mutual understanding of a research topic that's really grounded in the perceptions and experiences of participants. And for this methodology, we refer to our research participants as conversational partners because we believe in this method that they are a partner in the research with us. So analyzing this content I use something called qualitative content analysis. That was a very daunting task. With qualitative research, you probably had about 500 pages of data that I had to go through. I'll spare you the details on how I analyzed that. And field notes kind of helped me keep track of important things during my interviews, such as kind of checking myself for bias or role confusion. Sometimes it's hard as a nurse when you're meeting with them as a research participant and they have questions about their health. It's really hard to step back and not answer those questions or address their concerns because your role there is really as a researcher. I did use convenient sample and purposive and small wall sampling, and most of my participants I recruited through the Rhode Island American Parkinson Disease Association, and I actually probably got the majority of my participants who contacted me through their Facebook page and a post that listed the study and its purpose. So just quickly, demographics. Again, this is qualitative research, so we tend to have a smaller sample size. So I had 8 participants, 6 men and 2 women. These are pseudonyms, obviously, to protect identity. The age range was 57 to 78 with an average of 65.25. The average years that my conversational partners had Parkinson's was 5.5 with a range of 2 to 9. I did not have a very diverse sample. All were white. 6 were married. It was a pretty highly educated sample with a couple people having PhDs, master degrees. And 3 out of 8 of my participants were still working full-time. So this chart represents my themes. When you do qualitative research and you comb through all of your transcripts, because my interviews were recorded, they were transcribed by a professional transcriptionist, then you have to start going through to kind of identify themes per research question. So we're going to focus on the area in this kind of nice mint green color. For the second research question looking at quality of life, the major theme that arose for that was accommodation and loss. So underneath each heading, you see TH3, TH4. These are sub-themes that identified. So when I looked at accommodation as a major theme for quality of life, one of the sub-themes were alteration in daily routine. With loss, the sub-themes were role loss, loss of activities, and changing sense of self. The third research question had to do with self-management. And self-management came up, the theme accommodation came up again. So while accommodation, and I'll talk a little bit more about that in a minute, was distressing to many participants, it was also a way that they managed their fatigue. And sub-themes there, engagement in activities, particularly exercise and conservation of self, kind of using those pacing techniques and rest periods. Mental fortitude was also cited as a self-management strategy. So many participants, practically all of them, talked about taking control, persevering through their experience of having this debilitating fatigue, finally accepting that this was part of their life now, this symptom, and positive attitude. The fourth research question had to do about healthcare providers' interactions and their experiences with having their provider address and manage fatigue. Seeking validation was a big sub-theme. They really wanted to know that, why do I feel this way? Is this Parkinson's? Is this something else? And then taking control and kind of persevering again through office visits with their provider and making sure that they really were letting their provider know that, hey, this is a problem and, you know, we need to discuss it and come up with some strategies to manage it. So I like to include some quotes because this really gets into the nitty-gritty of qualitative research and really brings our patient experience to the forefront. So one of my participants said, and this is pretty universal to each of those 8 conversational partners that participated in my study. She said, I'm planning my life around it. I have changed everything to accommodate it. So this person still worked full-time, and she had to restructure her workday, even the way she commuted, the way she took breaks. That's just one example. She was not able to go out at night anymore because that was when she felt really fatigued. And interestingly enough, most of my participants had to plan their day to have everything done in the early morning, early afternoon, because come late afternoon, they were wiped out. So in a sense, accommodation really created feelings of frustration and disappointment. Some of my participants did have to stop working because specifically due to their fatigue. Others also had to miss important events like going to the theater or attending groups, chorus practice, art club, things like that they could no longer do because it just was too much for them. It taxed them too much. Something else that was very interesting was continuous modification. So Bill mentioned that every day is a new day. He'd have to get up, see how he feels, and then kind of change his schedule, cancel things, reschedule things depending on how he felt. And that was a continuous, ongoing effort. And most of the participants felt that way as well. Social support, largely positive experiences. All of my participants had supportive family and friends and social networks that were okay with them having to restructure their day and activities around their symptoms. In the MS literature, the multiple sclerosis literature, that's a little bit of a different finding where there was a lot of conflict among family members and people not really understanding that this is a real part of their illness and getting frustrated with their loved one who had significant fatigue. So in my study, I found the opposite. So accommodation also includes self-management strategies. So what do people do to reduce or lessen the fatigue that they have? The biggest thing that everyone in my study felt was highly, highly valuable and helpful was exercise. Boxing was a big positive influence on their lives. About half the participants were doing boxing, specific for people with Parkinson's. They felt like a new person after they would get out of class. They felt less fatigued. It would last into the next day. And some of my participants even said, when I am exercising, doing the boxing, I don't even feel like I have Parkinson's anymore. I had one participant who called himself the Zumba King. He said Zumba was really helpful and reduced fatigue. Bicycling and like strength training was also helpful, as well as chair yoga. Other self-management strategies were taking rests, naps, and again, that whole restructuring of one's day and even life to kind of manage this symptom and accommodate for the way they feel. So loss, this has to do with quality of life. Like I had mentioned previously, some of my participants had to stop working due to their fatigue, and this was very troublesome and stressful for them. Social, so the inability to participate in leading art classes, attending chorus practices, theater clubs. So just kind of losing things that they could do before. They've had to give up a lot of social activities, or not being able to even go out with friends or family to dinner at night, because that time of day is when they really, really were very symptomatic. Family responsibilities, role loss, so losing the ability to bring in income, and also not being able to participate in some household chores and different things they used to do around the house really created some feelings of frustration, sadness, and feeling like they're disappointing their family. And then fatigue was cited as being very isolating, again, especially for those people who had to reduce their social activities or career activities as well. When I was talking with one of my participants, Pat, I thought this was so interesting. So Pat had fatigue for a very long time, and she brought it up to her provider many, many times, and they told her that it wasn't associated with Parkinson's. So she actually watched a webinar on the Michael J. Fox Foundation all about fatigue and Parkinson's, and then she went back to her doctor, brought it up with the provider again, and the person still said, well, there's really nothing we can do about that, and didn't offer any interventions, which is unfortunate. So a lot of my participants ended up researching fatigue on their own and finding out, oh, yeah, this is a big problem. This does go along with Parkinson's. The few who did have providers who assessed for this symptom or provided information about interventions or strategies, recommended exercise as the number one thing to do, and stimulants. So sometimes methylphenidate, which is Ritalin, those types of medications can help as well. And the people who were on stimulants did feel that it helped the kind of mental fatigue, brain fog they called it, but not really the physical body feeling of fatigue. That was helped more with exercise. So definite limitations with qualitative research. They're not meant to be generalizable because such a small, and I had such a homogeneous sample. This is a highly educated sample overall. They had good social support. They had access to resources, access to transportation to get to their doctor's appointments. They had computers. They were internet savvy. This study would look very, very different in an underserved community. Social desirability bias is always something you have to consider when you do qualitative research and interviewing, because sometimes your participants, they don't want to disappoint you and they want to appear positive. So that's definitely something to take into consideration. As I mentioned, the methodology is limiting, especially for people with Parkinson's, because as we know, many people have difficulty speaking, memory problems, and that could really interfere with somebody's ability to answer questions. And then subjectivity of fatigue. So for this study, my participants self-identified that they had this symptom. I did not use any scales to assess for fatigue severity, like using a fatigue severity scale. So that could be a limitation as well, because did they really have fatigue or was this something else? So ongoing recommendations, future directions, curriculum changes, education. Those of us who are in the academic world know that nursing textbooks really have little to no information about non-motor symptoms in Parkinson's. It's really, I teach advanced pathophysiology. They don't even mention non-motor symptoms in my textbook. Looking at research, I mentioned content analysis and non-motor symptom cluster. Fatigue tends to go along with depression and apathy. So if people experience these symptom clusters, can we as nurses and providers develop a treatment strategy to address all of those symptoms? Resiliency, this is a very resilient group of individuals. So how would this study look in people who didn't have resiliency as an inherent characteristic? Using fatigue scales in practice to identify those with fatigue. And then how do caregivers view fatigue? I didn't include caregivers in this study, but I'd be really interested to know how does it affect their life and what do they see is going on with their loved one? So in clinical practice, really making sure we identify this symptom, we assess it in office visit, we teach about self-management strategies such as exercise and policy. So again, most insurance companies, health insurance companies, Medicare don't pay for gym memberships. So what about the population who can't afford to go to classes or doesn't have access? So that's something to look at a national level. And nurses overall, we're in a perfect position to help develop those policy changes, make exercise more accessible and affordable, and advocate to increase knowledge of not only Parkinson's related fatigue, but with other non-motor symptoms. And that concludes my part of the presentation.
Thank you very much, Dr. Bruno. It's a very comprehensive review of the literature in fatigue and also very insightful on what nurses can be thinking about and developing interventions for this most difficult symptom patients try to manage. We'll have a lot of opportunity at the end of our next speaker's presentation to ask questions of both of the speakers. So at this point, I'd like to introduce our second speaker. Dr. Dahodwala is trained at Columbia University and the University of Pennsylvania, where she currently practices in the Parkinson's Disease and Movement Disorders Center. In addition to her medical training, she holds a master's in health policy research from the University of Pennsylvania. She has researched and published extensively on health disparities, literacy, mood, and sleep in Parkinson's, and most recently has been funded by the Parkinson's Council to refine a smartphone application on a behavioral intervention to treat apathy in Parkinson's disease. It's my pleasure to introduce Dr. Dahodwala, who is a colleague of mine at the University of Pennsylvania and who I have the utmost respect for her research. Thank you, Dr. Dahodwala.
Thank you, Gwen. Thanks for the lovely invitation and introduction and invitation to speak today. I'm sorry, next slide. So as Gwen already did in the beginning of the talk, spoke about the importance of non-motor symptoms, I was just going to reiterate that they're often under-recognized and they contribute greatly to lower quality, health-related quality of life, higher disability, and healthcare costs. And apathy is one of these non-motor symptoms that is similar to fatigue in that it's somewhat hard to define and for patients to speak about. Traditionally, and for the past 30 years, the classic definition of apathy has been a lack of interest, enthusiasm, or concern. And as you can probably imagine, this is very subjective in how one might interpret that definition and people's perception of whether this lack of interest is because they're depressed or that they have cognitive impairment or that they're tired or fatigued can be very challenging. And so more recently, there's been a push to reframe how we think about apathy as an impairment in goal-directed behavior. So we all have innately goal-directed behavior that constitutes different parts, which is we have to initiate a plan to complete a goal. We then have to plan it out and then ultimately perform that activity based on how motivated we may be. And there may be some rewards that we get from it or a punishment if we don't complete it. And those 3 steps are the main components that constitute goal-directed behavior. And using this framework to think about apathy, I think becomes really useful. Next slide. And because we can then more objectively ascertain what someone's behavior is. And this is, I'm going to just spend a little bit of time talking about my research on trying to measure goal-directed behavior. And the figure on the left-hand side shows at the very top the constructs that we're trying to identify, which is how someone initiates a behavior, how someone plans that behavior, and then the motivation that leads to the accomplishment of the behavior. And if you kind of follow those constructs down, you end up with the achievement of goal-directed behavior. But if you look along the way, there may be some genetic changes or molecular deficiencies that lead to impairments in those activities. There's circuitry that's involved, and we know from neuroanatomical studies that the anterior cingulate cortex is highly involved with the initiation of behavior, that the dorsolateral prefrontal cortex is involved with planning, and that the orbitofrontal cortex is involved with motivation. So when you have injuries to those parts of the brain, you have selective impairments in goal-directed behavior. And what we wanted to do in our research was try and measure that behavior more objectively than a scale that asks you to subjectively report how you're feeling. And we developed a computerized reaction time-based study test that is controlled for their motor slowing to assess their speed for initiation, speed for planning, and speed for motivation. And the figure 3 on the right-hand side kind of gives you an idea of how it works. So it's the participant will have a laptop in front of them, and they're asked to hold down a key. And then when there's a signal on the screen, they're asked to then move to another key. And that we break down the components of that to measure how fast they initiate that behavior. And then we change the scenario so that they have to plan which way to go based on what they see on the screen. They actually have to use some executive function to determine which side to go to. And then lastly, we add in some motivation to the task where they get either a reward, they'll get more money if they complete the task faster than they had before, or they get a penalty. The money will be taken away from them if they don't. And using that task, we were able to see differences between people with Parkinson's disease and what traditional apathy and people without apathy. And then secondly, in the figure 2, what we were able to show is that those impairments in the different tasks of our computerized test related to the same circuits that we hypothesized were involved in initiation, planning, and motivation. So the top level on figure 2 are the coronal sections from the anterior cingulate cortex, the dorsolateral prefrontal cortex, and then the orbitofrontal cortex. So it was a nice kind of example of trying to get at the pathophysiology of this behavior so we could better understand how to identify people with what we call apathy clinically, and then ultimately how to treat it. If there really are these different contributing factors that ultimately lead to impaired behavior, where can we target, how can we target our interventions? And that's what led to this smartphone app that I can talk about more at the end. It's not on our slides, really targeting the underlying problems in behavior. The other reason I think this becomes really important, next slide please, is that, as Amy nicely mentioned, is that this is a symptom that is overlapping with a lot of other syndromes. So apathy can be a symptom of depression, of cognitive impairment, of fatigue. It can also be its own distinct syndrome. And understanding that complexity of where the actual root of the problem is really will help us develop the best treatments for it. If the end result is a certain behavior and we don't know what it's coming from, it makes it really hard to develop interventions for that problem. Next slide, please. So how common is apathy? again, the challenge here is how do we define apathy? And that has led to a lot of different reports where ranges from the frequency of apathy range from 14% to as high as 60%. And in fact, in studies where there's a higher degree of cognitive impairment in the sample, it's almost universal that apathy is a symptom in Parkinson's disease. So depending on who you study and how you measure apathy, the range can vary, but it overall is under-recognized and relatively common. And to just give you some perspective, in the general community, a sample of older adults, the proportion of people with similar impairments in goal-directed behavior is about 20 to 30%. Next slide, please. So what are the consequences when you have impaired goal-directed behavior or apathy? There's a decreased ability to complete your normal activities of daily living. You have a lower quality of life. There's a lower adherence to treatment plans, including less exercise, which is extremely important in a disease like Parkinson's disease, where exercise is potentially one of the better treatments we have. And then a resulting higher caregiver burden. Next slide, please. Next slide. So what do we do? How do we treat apathy? There's no one perfect treatment for apathy, and in fact, the treatments that we have are still inadequate, but there has been some research on different medications for apathy, behavioral therapy, counseling, and then exercise and social engagement. Next slide, please. I'll start with medications. So there are no FDA-approved therapies, and there have been about 15 to 20 small studies of different pharmaceutical agents that are already approved for either depression or cognitive impairment or Parkinson's disease motor symptoms as kind of secondary indications if they were to be successful in treating apathy. These studies are limited in that they're small in number, they're not always randomized or blinded, so many of them have been just case reports or open label studies. And I think another limitation is that they use the main outcome that they're looking for is a change in a validated apathy scale. And it can be anywhere from a 1-point change, as long as it's statistically significant, to a 5 or 10-point change. But understanding what that change means, there hasn't been any real research showing what the impact of that is. Like, how does it actually affect the patient experience? In any case, if you think back to breaking down apathy into the underlying constructs, you can get a better idea of targeting treatment. So if there's more of this is a nice, the chart on the right is from a nice review by, I'm going to mutilate this last name, and I should know because my last name is really hard, Tagana Baraga, which breaks it down that if there's more of this reward motivation deficit, then a dopamine agonist or a stimulant like methylphenidate may be helpful. If there's more of this emotional distress component, then an antidepressant might help. If it's more along the executive function planning deficit, then acetylcholinesterase inhibitors, which is what we generally use for cognitive impairment, could be helpful. And if it's more of this autoactivation, difficulty with initiation, then perhaps a dopamine receptor agonist might be helpful. That being said, the literature on stimulants is mixed. The evidence for dopaminergics is probably the best. Antidepressants so far have not been, the antidepressant studies have not been positive in showing that apathy is reduced. And the acetylcholinesterase inhibitor studies have been most helpful when there's the sample that they're studying has dementia with their Parkinson's disease. But again, I would take that literature with some caution because of the limitations in the study design. Next slide, please. Behavioral therapy is another, I think, underutilized therapy for apathy. And this is really like targeted cognitive therapy to help understand what the underlying barriers are to completing different goals, and then developing personalized strategies based on individual needs to help overcome these. And I think, finding the right therapist is helpful, and sometimes it can be an occupational therapist or a psychotherapist, but that can be extremely helpful, especially when the problem is with planning, because then you can kind of sit down and work through how to organize your day and make sure that you complete the goals that you would like to. Next slide, please. Next slide. Exercise and social engagement is extremely important. However, as you can see from the graphic, in order to exercise, you already need some motivation. So I think it should always be a part of the treatment plan because it will only help even other symptoms. Even if it has a modest effect on mood and apathy, it will improve any movement problems, memory impairment, and overall well-being. I think the challenge is how do you get someone who's apathetic to be motivated enough to exercise? And that's where I think breaking down the goal-directed behavior into the constructs helps. If the problem is with initiation, you can help set up alarms. You can help set up a system of reminders to get people started. If the problem's with planning, you can kind of sit down with them and lay out a plan of activities of how to get to what classes you're going to go to at what times, and help the patient who's already having some executive dysfunction plan out the day. And if the problem's with motivation, to talk about what are things that could be motivating. It may be having a partner to go to the gym. It may be having some oversight, or knowing that you as a provider are keeping track of what they're doing, or just increased communication, that knowing that there's a support system out there that is encouraging them to keep up with their exercise. Next slide, please. So that's pretty much where I think the research stands with apathy. I think identifying more objective ways to measure apathy is a useful technique. I think maybe the slide got skipped or I missed it, but currently the way we assess for apathy are through some validated scales. And those scales range from the single item that's in the Unified Parkinson's Disease Rating Scale in the non-motor section. It basically asks if how much motivation do you have, and the responses are you can be less assertive than usual, that you've lost initiation or are less interested in activities, or you're completely withdrawn and have complete loss of motivation. So it's mostly focused on just the motivation construct or domain within apathy. There's what's called the neuropsychiatric interview, or also known as the NPI, which is a caregiver survey. So this is a survey answered by the caregiver. There's versions. There's a short version and a long version. The short version basically just asks, similar to the UPDRS, but from the perspective of the caregiver, if the patient with Parkinson's is less interested or motivated in normal activities. There's some longer scales, like the Stark-Steen apathy scale, which has 14 items, and it also tends to be mostly focused on motivation and interest in doing things. And I think these scales have value. Again, the main limitation is that they're subjective. So from the patient, if the patient's filling it out, it can be, if they lack insight into their behavior, the responses won't be accurate. And from a caregiver perspective, if they're highly burdened, or if they're misinterpreting signs of Parkinson's disease, like their motor slowing or their masked faces as being disinterested, they may also provide less accurate answers. So that's why, in my opinion, these more objective ways will be helpful, and it'll help differentiate this more specific impairment in goal-directed behavior from other non-motor symptoms like fatigue or depression. And then ultimately, we really need better treatments for apathy and related depression, cognitive impairment, and fatigue, so that we can, improve overall quality of life and reduce caregiver burden. Next slide. That wraps up what I wanted to talk about today. And I just wanted to leave you with one of Homer's famous quotes, which is that I'm famous for my motivational skills. Everyone always says they have to work a lot harder when I'm around. So thank you, everyone, for your attention, and I'll leave it back to Gwen.
Thank you very much, Dr. Dahodwala. That was a wonderful presentation on apathy and current state of the research and also things to consider in helping our patients. At this time, we're going to open up the question and answer period. Please note that your questions can be submitted by clicking in the text messaging box on the bottom left corner. You type in your questions and then hit send, and we will try to answer as many of them as we can during our remaining time. So we have one question that has come in, and it really has to do with sorting things out, I believe. I know that we pretty well recognize that if there's a sudden change in mental status, we really think about a concurrent condition such as dehydration or infection and that sort of thing. In my experience, I've also found people who complain of just being too tired to do anything or to start and get involved in anything. And we know that fatigue and apathy can both be perhaps the source of these, but I think there are other differentials that we as healthcare providers need to just keep in the back of our minds as well, such as orthostatic hypotension. We already talked about sleep disorders and depression. To both of our speakers, are there other conditions that we should also keep in mind to make sure that we are not missing a concurrent medical condition that is slowly evolving?
Hi, this is Amy. That's a very good question. One thing that I think that we as providers should be very cognizant of is polypharmacy. So doing a careful medication review and seeing if the individual is on medications that interact and cause excessive CNS, central nervous system depression, if there's anything that we can reduce or eliminate or simplify their med regimen, sometimes that can make a difference. Also, as people get older, they experience multiple comorbidities, so looking at other things like ruling out anemia, other metabolic issues as well, and doing a good sleep assessment to see, is this person taking too many naps during the day? Can we restructure sleep time and sleep schedule, sleep hygiene? Things like that are other things that I know that I consider.
Very good.
I would agree with everything that Amy said. I think they all apply to apathy as well. The polypharmacy and very clear sleep history. The only things I would add are, I think, a good medical exam if you're worried about another cause for apathy, that, if there was like a second neurological condition contributing, you would identify that on exam with either a change in reflexes or weakness or some new symptoms that are beyond the Parkinson's disease. And then the last thing would be the acuity of onset. Like if there was a really sudden change in behavior, I would worry about something like an infection or like an acute metabolic condition, as opposed to this apathy and Parkinson's disease, which would really be like a slow onset and slowly progressive and worsening.
That's very helpful. Thank you so much. Okay, another question has come in regarding apathy. In depression, we often find weight loss or weight gain. Do you know if apathy causes any weight loss or weight gain? Has it been looked at?
That's a great question. It hasn't been looked at, and from the studies that use the validated apathy scales to identify apathy, there hasn't been any reports of weight changes or weight loss. I think when apathy is comorbid with depression, then you can see, usually I think in Parkinson's disease, weight loss. But in general, the weight gain, weight loss are not as useful as a measure, a symptom of neuropsychiatric symptoms or of depression or apathy in Parkinson's disease, because it can be an independent feature in Parkinson's disease.
Thank you very much. Question has come in regard to both fatigue and apathy. So, Amy, if you'd like to answer first, and then we'll hear from Dr. Dahodwala. The question is, have you thought about giving any of the questionnaires on fatigue or apathy to both the person with Parkinson's and then also their mate or caregiver, and then comparing the two?
This is Amy. I have thought about in the future. I definitely would love to explore the caregiver's experience of having a partner with Parkinson's-related fatigue, and I think that actually could make for a really good study to see if their opinions are consistent. Because I do think especially I remember one of my participants, he told me, if you ask my wife about this fatigue, she would say I'm perfectly fine because he's so busy. He cooks, he cleans, he goes to Zumba, he does all of these things, but he feels horrible every second of the day. He just keeps going. So I think that would be an interesting thing to further explore.
And from the apathy standpoint, researchers have done this. And what's interesting is that when the patient has comorbid cognitive impairment, the patient tends to underreport the apathy, whereas the caregiver presents a picture where the apathy is higher than the patient does. And then the reverse, when the patient has comorbid depression, the patient tends to report a higher degree of apathy than the caregiver does. So they're not always totally concordant, although they're usually correlated.
Very interesting. Thank you. Thank you. So a very good question has come in regard to cognitive behavioral therapy in fatigue and in apathy. And I believe, Dr. Dahodwala, you mentioned this briefly. How do you find the right cognitive behavioral therapist for really any of the issues of Parkinson's that we want to discuss, but in particular fatigue and apathy? Do you have any hints for our audience on that?
Well, so this is Nabila. I'll go first here. I do think this is really a challenge. I think finding allied health professionals that are familiar with Parkinson's disease can be hard. So if you can be associated with a center of excellence or a Parkinson's disease center, they usually have some network of referrals that we use. So, at our center, there are some therapists that over time we've become more familiar with, but it is a process of, understanding, of knowing who's more familiar with Parkinson's disease than other people in the community.
Yes, and I would just add on, it's in my practice area, which is on the south coast of Massachusetts, it's extremely challenging to find good cognitive behavioral therapists and therapists in general that have more of a geriatric specialty. So a lot of times we do referrals to the greater Boston area, but again, that's not realistic for a lot of people. So we need more mental health providers, bottom line, but that's a whole other discussion.
Right. Thank you. A question from our audience. Amy, you had mentioned Zumba and exercise, and the question is, I'm surprised to hear that Zumba may help. Should it be modified to avoid falls, or do the chair Zumba or a modified Zumba class? I know you mentioned one person that you interviewed was during Zumba. Do you have any comments on that or any information on that?
Yes. So most of and I can only speak to my participants, were going to local community centers or the Y that actually had exercise programs specific to people with physical limitations or Parkinson's, other conditions as well, like multiple sclerosis. So their instructors were very, in tune to certain needs aids, for the yoga, providing the chair. And also people, again, I had a sample that kind of knew their limitations, so they would be able to take frequent rest. But I think if people can find exercise instructors, fitness instructors who are knowledgeable about chronic health conditions, neurological conditions, that's probably the best bet because they have a lot of adaptive equipment that can be available.
Wonderful. Thank you. Thank you very much. A question about apathy. How can we help our caregivers to understand that apathy is part of the disease and not just the patient's mood or behavior, that it really is part of Parkinson's? Dr. Dahodwala, can you comment on that for us?
Yeah, I think that's an excellent point that I didn't talk about in the webinar, but sometimes the caregiver may blame the patient for their lack of motivation or lack of interest in participating in daily activities. And I think the first thing that you have to do is recognize that apathy is present. And so that may be screening for apathy, asking about questions on goal-directed behavior. And then I think the next part of that is education, educating both the patient and caregiver once it's been identified in the visit that this is a common part of Parkinson's disease, and just explaining what it is so that they can start to think about strategies to help deal with it and remove the blame from the patient and more about that this is coming from the disease. But I think the first step is really recognizing that apathy is present. And I don't think it comes up often in conversation unless you ask about it.
Thank you so much. Dr. Bruno, what do patients want providers to know about fatigue and Parkinson's?
So one of the, looking across my participants, is they really just want to know one of their most confusing things is this Parkinson's? Is this because of my medication? Many were completely unaware that non-motor symptoms were so disabling. So they really want their providers to ask about these symptoms and offer some strategies or interventions to treat them. I think the bottom line, increased awareness and just acknowledgement that this is a big problem for them.
Our last question has to do with the diet. We have a caregiver who asked the question, does food, diet, caloric intake, etc., have anything to do with improving fatigue and apathy, and is there a role for food as a motivator in Parkinson's disease?
So this is Nabila. I don't know of any foods that are helpful in apathy. There was a small study from Japan that looked at an herbal supplement, and it was a negative study. So I don't think there's anything specific for apathy, although there may be changes in diet that give people more energy in some way, but I don't know what the data on that is.
Okay, fair enough. Okay, we're just about at the conclusion of our webinar today. Up on your screen, you will see the webinar survey that we'd like you to submit. Your feedback really helps us to improve our webinars to ensure that we get the information that we need. If you're interested in CEU credit, please watch for the reminder email and use the link to receive your CEUs. Please allow up to 60 days to receive your CEUs after the application request. Our next webinar will be held on March 27th, getting my years mixed up, March 27th, 2018. And the topic will be on caregiving, research, and intervention. It will be held at 1 p.m. Eastern Standard Time. I'd like to thank our speakers today, both Dr. Bruno and Dr. Dahodwala, who really provided an excellent session on understanding fatigue and apathy and giving us a lot to think about, both from the provider point of view, but also if there are patients listening, I think real helpful information was shared on how to think about it and talk about it in your medical visits. So I thank both of our speakers for an excellent job today, and I thank the audience for attending. An archive of today's event will be made available starting next week on Tuesday, December 12th by visiting www.parkinsons.org. Thank you very much. This concludes today's program.